A very good evening and a warm welcome to all in this 11th session of Tuesday Takes brought to you by Women's Committee Maha IP and Maharashtra IP. Myself, Dr. Sonali Shirbhate, and my co-host Dr. Neha Singh and Dr. Manjusha Sherkar for this session. Once again, Women's Committee welcome our President, Maharashtra IP, Dr. Ramakant Patil sir, our Secretary, Maharashtra IP, Dr. Amol Pawar sir, for their extreme guidance and help for this session. We are very fortunate enough to have our guest of honor as Dr. Himmatrao Baviskar sir from Raigad, who has a lot of work in the field of envenomation, especially the scorpion bite. So, welcome, sir.
Thank you.
I welcome our experts, Dr. Sampada Tambulkar, madam from Pune, and Dr. Prabha Khaire, madam from Sambhajinagar. We are very
Thank you.
fortunate that we got you for this session. I welcome our all dear faculty speakers from all zones of Maharashtra. I welcome Dr. Aditi, Dr. Shreyas Surpure, Dr. Prasad Dharm, Dr. Swapnil Talvekar, Dr. Kshitij Munde. I also welcome our all OBs and EBs of Maharashtra IP. I welcome Dr. Gangolia sir and all the dignitaries present in this session. And most importantly, I welcome all my dear lady EBs from all zones of Maharashtra. Because of their hard work, all the sessions of the Tuesday Takes are possible. I would like to thank you, Dr. Neha Singh, my co-chairperson, Women's Committee, Dr. Manjusha Sherkar, convener, Women's Committee, and all zonal EBs, Dr. Pallavi Patil, Dr. Mangai Sinha, Dr. Grivita Raikar, Dr. Shilpa Dudgaonkar, Dr. Nivedita Patil, Dr. Sonal Shinde, Dr. Manjusha Giri, Dr. Swati Patil, Dr. Sucheta Pofre, and Dr. Dipti Deshmukh for this session. Thank you very much and a very happy Christmas to all. It's December 2023. We Women's Committee are happily came to the end of the Tuesday Take session. So this is the concluding session of Tuesday Takes today. As you all know, in all previous 10 sessions, we had taken all the speakers from all the zones of Maharashtra, and I had given chance to all the upcoming dynamic young team. So we had given 55 new speakers up till now in the whole year, as well as we had taken credit points in every session. So we had given 12 credit points up till now for these Tuesday Takes sessions, as well as we had got the guidance of 19 renowned expert judges for this session. So I am thankful to all the speakers and experts for the whole year. In the day-to-day practice, as you all know, we encounter various stings and bites and envenomations. We must know the protocol management of these bites and stings. So the theme of today's session is envenomations. So let us know more about this from our experts and the dignitaries. So for further proceeding, I would like to hand over mic to Dr. Neha Singh, our host for today's session.
Thank you, Sonali ma'am. That was a great start for today's program. A very good evening to all the respected dignitaries, seniors, colleagues, experts on Maha IP Zoom as well as YouTube Live. Welcome all on behalf of Maharashtra Academy of Pediatrics and Maha IP Women's Committee for today's program of Tuesday Take. I, Dr. Neha Singh, Maha IP co-chairperson of Women's Committee and practicing pediatrician from Navi Mumbai, Raigad district, as well as my co-host Dr. Manjusha Sherkar ma'am, convener Maha IP Women's Committee from Chhatrapati Sambhaji Nagar. We both are the moderators for today's program. Friends, today's being the last episode of Tuesday Take of our tenure. Myself in 2022 started as editor of Maha IP and Maha IP Women's Committee. Then Dr. Gangolia sir was our president and he ignited the formation of Women's Committee in Maha IP, and we were a team of 13 members. Dr. Renu Poralkar ma'am as chairperson and Sonali ma'am as co-chairperson, myself as editor, and we had 10 zonal coordinators from all over Maharashtra. This year in 2023, under the able presidentship of Dr. Ramakant Patil sir, as protocol, Sonali ma'am became the chairperson and myself as co-chairperson. We all agreed to continue with this program and new team of 10 zonal coordinators. I'm really I really appreciate and thankful all our coordinators from Maharashtra who have helped and supported both of us in our 2023 tenure. The entire Women's Committee together, we all conducted so many other IIP programs too at our area and promoted MahaIP Women's Committee to a next level. Our patrons, Dr. Swati Bhave ma'am, Dr. Sandhya Khatse ma'am, Dr. Bela Verma ma'am, and Renu Borelka ma'am, who are distinguished personalities in their levels, also showered us with their love and guidance. Continuing today, also with this unique concept running for last 2 years with topics coming to our OPD practices. And here we have 5 speakers from different areas of Maharashtra allotted with 5 different topics. Each speaker gets 8 minutes to present. And we also have with us 2 experts for guidance who will give their expertise comment after each topic. Topic of today's program is envenomation. And our world, in this world, man and nature are in a love-hate relationship. The reptiles and arachnids have developed skills to survive in a world where dinos and hippos have become extinct. They stay in their habitats, but when men encroach their territory, they sting. Friends, please note today's program has been allotted 1 MMC point. So requesting everyone to please type your name, city name, central IP and MMC registration number in the chat box. Now I welcome and request our Maha IP President and Central IP EB member Dr. Ramakant Patil sir to kindly give his blessings. Over to you, sir.
Thank you, Neha. Very warm welcome to all dignitaries. Padma Shri Dr. Himmatrao Bavaskar sir, Prabha Khaire madam, HOD Pediatrics, Chhatrapati Sambhajinagar Government Medical College, Professor Dr. Sampada Tambolkar madam, Head of Unit and Professor in Dr. D.Y. Patil Medical College, Pune, and all the young faculty for today. Most of them are below 35, not even below 40. Barring one respectable example, Dr. Prasad Dharm, but all are less than 40. And this is what is the credit of this women's wing of MahaIP. Is ably led by Dr. Sonali Shirbate, ably supported by co-chair Dr. Neha Singh, Manjusha Sherkar, Priya Pallavi Patil, Dr. Swati Sachin Patil, Dr. Mangai Amok Shahane, Dr. Sucheta Pofre, Dr. Deepti, Dr. Swati Patil, Dr. Shilpa Dudgaonkar, all these committee members, they have done wonderful job. And it is a mixed feeling today. Now this is, we are probably having the last online session of MahaIP under my tenure as a president. Fortunately, Dr. Amol, who is again EB member and will be continuing as a secretary. So this glorious work of MahaIP will continue and there will not be any halt or hitch. What has been ably started by my predecessor, Dr. Hemant Gangulia sir, and he has innovatively started so many programs, and we were very happy and privileged to continue those 4 programs. In addition to that, we added our own flavor in form of path for adolescent program and immunization dialogue, and we had that additional, and it was a wonderful work, and this is possible only because of team. For this Tuesday takes Sonali, Neha, Dr. Manjusha, Pallavi and their team members. For Subspecialty Connect, Dr. Sachin Patil and Dr. Samir Sadavarte, ably advised by, supported by Dr. Sham Chaudhary, Vice President, and Dr. Prashant Jadhav. For PATH, Atul Kanikar. For Immunization Dialogue, Dr. Sanjay Lalwani, Dr. Sanjay Marathe, and Dr. Rajendra Khadke from Aurangabad. And all those programs which were like MahaIP Katta by Dr. Milind Baradia, all these programs were continued, and case challenge by Dr. Pramod Kulkarni, ably supported by Dr. Deepa from Kolhapur and Dr. Anjali Gokarna from Virar or Palghar district. So this is really, I feel looking back at 1 year that we have accomplished, but there is so many things to do. अभी तो मुट्ठी भर जमीन आपी है, अभी पूरा आसमान बाकी है, और वो आसमान तो अमोल और राम गोपाल चेजारा करेंगे. और with this, what another wonderful topic to end with, innovation. It is a love and hate relationship, as Neha has said. we have on one side we have to promote one health, we have to associate with zoonosis and all mankind, plant kingdom and everything. So this is one health concept. At the same time, we have to prevent this zoonosis. We are slightly blessed in Southeast Asia. Most of the exposure has occurred with zoonosis, and we have lesser and lesser exposure and chances of getting zoonotic diseases. But still, those are not less. Similarly, for ASV, we have got scarcity of ASV, and many times wherever it is available, it is indiscriminately being used. And this concept was posted by Dr. Bavaskar sir in 2001 in Lancet, the same sentence. We have got both the things, scarcity at the same time indiscriminate use of ASV. And what a path breaking work of scorpion bite, what everybody was doing, but a simple prazosin had made a difference of life in this scorpion bite, in particularly in children. And Bavaskar has not only done work, Dr. Bavaskar sir has not only done work only in ennomination or scorpion bite, but he has got pioneering work in cardiovascular diseases and also work in hypothyroidism. And we have got ably other two professors and HODs of Dr. Khaire madam and Dr. Sampada Tambolkar madam. And with this, I hope all the best for this today's program. And also I wish all the best for incoming President Dr. Ram Gopal Chezara and team under his presidency. And fortunately, Dr. Amol Age is going to continue as a secretary. So thank you, Neha, for giving me an opportunity to interact with all of you. And I'm really happy that such a wonderful topic is being chosen by you and the wonderful faculty. It is privilege to work with you all. Over to you, Neha.
Thank you so much, President Sir. Really, with those words of encouragement, we proceed. And I now request our dynamic Maha IIP Secretary General and 2024 Central IIP Executive Board Member Dr. Amol Pawar Sir to please share his views. Over to you, sir.
Thank you, Neha. First of all, welcome dear Dr. Himmatrao Bavaskar Sir, who is a Padma Shri awardee in 2022 for his extensive work in scorpion stings and various innovations, and he has done exclusively great work in the rural area as a medical officer in government setups, and now he is also continuing as a physician in Mahad in his Bavaskar Hospital, and he is treating many of the needy patients of his area of interest. Then welcome Dr. Sampada ma'am, then Dr. Prabha ma'am, past President Dr. Hemant Gangulia sir, and many of the viewers, delegates, and today's speakers, and three wonderful ladies and their team of 10 zonal EDs. Dr. Sonali ma'am as a chairperson, Dr. Neha as a co-chairperson, Dr. Manjusha ma'am as a convener of Maharashtra IIP Women Committee. Three of them, and along with their zonal EDs, have done wonderful work in last 12 months, taking along the young speakers and involving them in various webinars on different topics. Everything has been explained by President Dr. Ramakant Patil sir, and under his presidency, this is the 12th month of the year 2023, and many previous tasks set by Dr. Hemant Gangulia sir and myself in last year, we have continued, and many new programs we have initiated and completed successfully, immunization dialogue and SPARK and various other programs also. So without wasting time, I welcome again Dr. Himmatrao Bavaskar sir from Team Maharashtra IIT, and hand over to Neha, and we'll have some words initially from Dr. Himmatrao Bavaskar sir, and then we'll proceed to speakers. Welcome, and all the best to all the speakers also. Back to Neha.
Thank you so much, Amol sir. Friends, today we are blessed to have with us respected Himmatrao Bavaskar sir as our guest of honor. Sir needs no introduction. We all know very well He is a physician, scientist, and founder of Bavaskar Hospital and Research Center in Mahad, Maharashtra. He is globally recognized figure for pioneering research on the management of scorpion sting, snake bite, and venomation. Much of his work has been published in the British journal The Lancet. He has also conducted research in the field of snake bite, cardiovascular diseases, hypothyroidism, CRF due to metal in drinking water, prazosin, and whatnot. He has been awarded with the Padma Shri Award in 2022 by the President of India for his research and social contribution. I welcome sir and request him to please give his blessings. Kindly unmute, sir. Yes, sir.
Sir, you are unmute now. You are muted.
Okay.
Yes, sir.
Yes. Thank you to all for their good words for me. Now, still we are working on the various different subjects because every doctor should know doctor is student till death. When he ceases to be student, he dies. So ultimately, everybody has to work till we die. The most important thing, what we face, the clinical medicine, which is on the way of dying, it is a duty of we clinicians should survive the clinical medicine now because we are becoming more dependent on the investigation, and investigation is deteriorating the clinical medicine very fast. So important thing which when I come to the Raigad district, the mortality of scorpion sting was 40%. It was still there for last 20 years. Nobody could able to try it. Why the mortality? Everybody is waiting for antivenom. So we studied detail, and then we come to know the vasodilator is a mainstay in the treatment, and mortality suddenly dropped down. Important thing is this is accepted in the world, and mortality from Israel, Trinidad, Mexico also reduced. Most profound, I want to remove the stigma attached to my head of the scorpion sting. Many other subjects I studied, that is hypothyroidism, then cadmium toxicity in Vidarbharism, which causes renal failure, then a homocysteine level which increased because of common cause of B12 deficiency. Then we are seeing spinocerebellar ataxia, fluorosis. We know the many fluorosis cases in this area, and most important snake bite. Snake bite, most important thing is a crate. Crate is a silent killer. It's a silent killer. A simple thing of use of mosquito net prevent the crate bite, which is often forgotten by the villagers. Now important in the bite and information, prevention is a mother of cure, rather than taking a patient getting envenom and treating is very difficult task. So my important message is that we should emphasize on the prevention of envenoming rather than the complicated management of envenoming. Thank you.
Thank you, sir, for the word of wisdom. Now I welcome Dr. Hemant Gangulia, sir, our immediate past president of MahaIP, who ignited the torch of Women's Committee and many other programs of MahaIP, to say a few words. Over to you, sir.
Thank you, Dr. Neha. She herself one of the great find of the year 2022, and we could find so many finds in the last 2 years.
Thank
And
you.
good evening, Padma Shri, Dr. Himmat Rao Bavaskar sir, our from Raigad, and all guest experts, Dr. Prabha madam, as well as Dr. Sampada madam. Really, just I want to say one thing. In year 2022, the concept of this arise actually came from the Mahapedicon 2019, which was held at Amravati. That it was a T20 session, 4 minutes, 20 speakers, 20 topics in 1.5 hours. It was a brilliant idea, and from there this idea came, and it was the MahaIP Women Committee, which was first formed in the year 2022, and then the chairperson, Dr. Renu Boralkar, and co-chairperson, Dr. Sonali Madam. And then we thought of the name of this, and it was really discussion among ourselves, our two, and myself and Amol, and we arrived on the Tuesday text. And so it took off in the last year, 2022, and now it carried also, thanks to Dr. Ramakant Patil sir, to carry forward this memorable thing of Tuesday text. And we have all, I think so last year, 2022, it was 11 episodes. This year it was 12 episodes. So in our 23 episodes, and we had in 23 episodes, we have almost 126 speakers, young, across the Maharashtra state. And we had the experts, almost 46 experts in this Tuesday Text event. It was a great thing to go. And I don't think so. Whatever I heard from the Mahaipivan committee, this is the last episode probably, because Amol is continuing. So Tuesday Tick should also continue, I think so. So probably this may continue 2024, and as protocol goes, probably this Mahaipivan committee, as per the protocol, will continue to work as a chairman, co-chairman, 10 zonal committee members, and all the best wishes to young, all three except one, all the speakers of today's Dr. Aditi Madam, Dr. Shreyash, Dr. Prasad, Dr. Sapnil, Dr. Kshitij, all the best for your talks, and I'm sure it will be very, and we are really fortunate to have a great clinician, Dr. Himmatrao Bavaskar. He's a wonderful person. He's from Raigad, and we will learn a lot of things from today from his as an expert also comments after the experts give their opinion. And I wish each one a happy learning session, and it will be a great learning session. Thank you very much.
Thank you, Gangolia sir, for joining us and giving your blessings. Dr. Rajendra Vasantrao Kulkarni, Senior Pediatrician, past EBM, Central IP from Nasik, is our MMC observer for today's program. Pallavi ma'am, has he joined?
I called him actually, but he has not listed. He may join soon. Please continue.
Okay, sir.
I would like to thank Dr. Gangolia sir to take the names of all the 5 speakers who are the typical, particularly celebrities for today's session. And this young, dynamic and academician from corners of Maharashtra are the major celebrities. Thank you, Gangolia sir, taking their name. They will be formally introduced, but it was very important. These are the celebrities for today. Over to you, Neha.
Yes, sir. True, sir. We have 2 experts for today, Dr. Sampada Tambolkar ma'am. She is professor in pediatrics at Dr. Pallavi ma'am, please show the... Yes. Ma'am is professor in pediatrics at Dr. D.Y. Patil Medical College, Pune. She has keen interest in adolescent social pediatrics, medical education, and she is member of Medical Education Unit and Board of Studies at D.Y. Patil University. Resource person and faculty of MUHS Degree Plus program. At present, Joint Secretary of AACCI Pune, past Joint Secretary of IIP Pune. 9 vaccine trials and 3 international clinical trials, especially the WHO trial for oral polio vaccine has been done by her. Appointed as reviewer of Indian Journal of Child Health, and she has indexed 20 publications. Welcome, ma'am. Our second expert is Dr. Prabha Khere ma'am. She is professor and head of pediatrics department, Government Medical College, Chhatrapati Sambhajinagar. Her area of interest is medical education, adolescent health, nutrition, cognitive behavior therapy, communication, and counseling. She has 28 years experience in medical training and teaching. She has been awarded with Dr. Prakash Kulkarni Gold Medal Award for Pediatric Postgraduate Best Teacher. She has spent more than 30 publications in national and international journals, paper presentation at conferences, faculty in BCME international and national conferences. She is doing public awareness, pediatric and adolescent health talks on radio, paper articles, and in interactive sessions in school. I welcome both of you, ma'am. So now I hand over to my co-host Manjusha ma'am for the further proceedings. Over to you, ma'am.
Thanks, Dr. Neha. Warm greetings to all the dignitaries and colleagues. First of all, we all bow before Dr. Bavaskar, sir. We are privileged to have you here, sir. Friends, without wasting much time, let us enjoy today's feast on envenomation. After welcome address,
Manjusha ma'am.
At BDBI Municipal Corporation Hospital, Mumbai. Can't hear?
Your voice is breaking.
Yes.
Okay.
Network issue hoga.
Yes. Okay. Dr. Aditi, please share your slides.
Municipal Corporation Hospital. Yeah. Okay.
Am I audible?
Voice is cracking. Dr. Neha, you can introduce.
Okay. Dr. Aditi, you can start your, yes.
Aditi.
Okay. Hospital Kandini. I'm going to talk about neurotoxic snake bite. So we have a case scenario in front of us. A 3-year-old boy played when
Slides are not moving.
both the eyelids were drooping and his speech was slurred. So didn't mother
It
to
is
the
not
Slides are not
care
moving.
center.
Dr.
Slides are
Aditi,
not
your
moving.
network there is network problem. Your voice is not coming properly.
Slides are not moving.
Please
And
keep
slides
your,
are also not moving.
Okay,
please keep
okay,
your
ma'am.
video off.
1 second.
Aditi, please keep your
Okay.
video off.
Yes, ma'am. Yes, ma'am. Is it okay now, ma'am?
Yes, yes, please.
Yes. So a 3-year-old boy who was playing in the fields, the mother noticed left eye is drooping. When he woke up, both the eyes were drooping and his speech was also slurred. So the mother took him to the doctor, the nearest healthcare center, and because the snakes were prevalent in the area, he asked for a bite or a history of a bite, but there was nothing. So on a suspicion, ASV was still given and supportive care was given. Thankfully, the child improved and he did not require any mechanical ventilation. So, like Bhaskar sir just said,
What do you say?
it may be so minute that you may miss. So, if there is a sudden onset neurodeficit, abdominal pain, vomiting with or without a mark, especially a snake bite. So the most common snakes, the most deadly snakes in our country are the Russell viper, the common krait, Indian cobra, and saw-scaled viper. We'll be talking about krait and cobra because they affect the nerves. So the krait venom prevents release of acetylcholine at the synapse, and the cobra toxin is the one which prevents it acts on acetylcholine receptors and hence prevents the conduction of the nerve impulse. So whenever we encounter a patient who has a suspected snake bite, we should do it right. So what does right stand for? Reassure the patient, because there is obviously going to be a lot of panic. Immobilize the affected limb. If you can see a mark, go to the nearest hospital and tell the doctor about any emergent symptoms. So this is how we would bandage the limb. Start proximally and bandage and immobilize towards the bite. Take the person on a scooter or a stretcher. The person should never walk because this would lead to the venom getting absorbed in the bloodstream. Take the patient to the hospital and management should be given as soon as possible. If we don't have bandages, we can use whatever available resources are there. So with this, it's also important to know what we should not do, and that is panic or go to any person who does not have sufficient knowledge about it. The cutting and sucking out venom is not recommended, neither is tying a tight tourniquet. Our bandage should be enough only to occlude venous and lymphatic drainage, not the arterial circulation. So we should monitor pulses when we are immobilizing and applying any herbal. So these are some of the signs that we might see with neuroparalytic snake poisoning and dyspnea because of the affection of the diaphragm. The bite may be as small as this, or it may be a bit larger, or there may be a very obvious local site necrosis. A summary of this, as you can see, local pain or tissue damage is not caused by the common krait, but is caused by most of the other snakes. And neurotoxicity is caused by cobra and krait. And so the cornerstone of our therapy is anti-snake venom. It is an equine immunoglobulin which is going to bind to the venom molecule, which will render it unable to bind to the target tissue. Neostigmine and atropine are supportive management. Neostigmine is going to prevent degradation of the available acetylcholine receptors, and atropine, of course, is going to prevent the muscarinic side effects of neostigmine. So intubation and ventilation if respiratory failure is there. 10 vials is the standard dose for all age groups. A repeat dose may be given if there is no improvement. And snake venom contains antivenom against the 4 most common snakes that we mentioned: the cobra, crate, Russell viper, and saw-scaled viper. Atropine and neostigmine can be given every 30 minutes. And if responsive, then we should continue at 1, 2, 6, 12, and 24 hours. Is there a role of traditional medicine? So we are not arrogant enough to say that there is no role. There have been animal studies, but till we don't know enough, we should stick to anti-snake venom, atropine, neostigmine, and supportive care should never be forgotten, including wound care. Because if there is a very bad necrosis and wound, we should not immobilize, or we should not tie a tight bandage. And when we like if we are tying, and if once we remove it, there is going to be a surge of venom in the bloodstream. We should give painkillers. We should avoid NSAIDs, tetanus prophylaxis, antibiotics, and dressing. So all of this to avoid complications that will require fasciotomy, debridement, amputation. We want to avoid all these things. There have been some progress in the latest technologies, best known to plastic surgeons. So we should involve them when we can. And of course, after all our care, there may be some complications we don't foresee. Locked-in syndrome because of widespread paralysis of all the nicotinic receptors, even the extraocular muscles. So the patient basically cannot communicate anything. With the genesis of new synaptic vesicles and new acetylcholine receptors, this may resolve. Compartment syndrome because of the bite, kidney injury because of myoglobin, and thrombotic microangiopathy, consumptive coagulopathy. So even after so much morbidity, snake bites are a neglected tropical disease. So September 19th is International Snake Bite Awareness Day. So some protection that we can do is personal protective equipment, especially when we are going into areas which are which have snake infestations. Some protective like awareness about first aid, availability of anti-snake venom, and most importantly, never ever provoke a snake. Just leave the snake alone. I have a small anecdote about this. This is a person from Pune called Nilim Kumar who spent 72 hours in a glass cage without provoking snakes and came out without a single bite. This was way back in 1986, but we need to remember that we should not provoke snakes till we can. I know it is easier said than done. So I end my short talk over here. Thank you very much for giving me this opportunity.
Now, this neurological bite is just a mathematics. This is like a mathematics. You see,
yes, sir.
In the crate bite, the typical history: patient sleep on the floor, woke up in the midnight with no local injury, no local paracetal, and progressive descending neuroparalysis. Pain in abdomen, chest pain, EC changes can occur, and that patient can be easily diagnosed as a crate bite. Crate venom is a presynaptic blocker. It destroys the presynaptic receptor. Just for regeneration research, we have to wait for a long time. That is the need. Ventilation is more prolonged required by the crate bite. Most important thing is neostigmine atropine has minimum role in the crate bite. And neostigmine atropine will not work. But early stage administration of antivenom is very, very vital. If you add early antivenom, minimum receptor will block. The recovery will be fast. That is very important. Remember, in the crate bite, because of presynaptic block, child can have a severe hypertension and pulmonary edema also, because release of postsynaptic receptor. In the crate bite, in the cobra bite, you have mentioned the day bite. Day bite, crate bite is rare. Day bite, crate bite is very rare, and during day bite occurs the envenomation is poor in the crate. But cobra bite occasionally is common seen in the day bite and early darkening. Most important difference from crate and cobra is a local sign. Severe pain at the bite site, swelling, edema, and blebs formation, and post-synaptic block, which is irreversible, total reversible. Suppose a patient of pulmonary edema come in acute respiratory failure to you, first drug of choice is a neostigmine, not the ASV. Because resuscitate the muscle first, and then you can give a most important local care. That is the most important thing. And patient can be salvaged rapidly. You see, here the time is a great enemy in cobra bite. As early as you give neostigmine, atropine, intubation, mouth-to-mouth ventilation, maintain the respiration, a patient will totally recover. That's a very, very important, because this, and most commonly in the crate and cobra bite, dilatation of pupil should not be taken as irreversible brain death. Many times I have seen a child was saying the child is dead. The doctor could not auscultate him. Heart was beating and child was discharged. So this is a very important. And next, third thing, the Russell Viper bite in our area, we don't have neurological, but in Kerala, we get neurological, but easily differentiate. Patient has a bleeding disorder with a neuroparalysis. So this is all just like in the neuroparalysis, in the crate, cobra, and Russell Viper, it's just like mathematics. Okay. Most important thing is never forget giving calcium gluconate in the crate bite, which improve the progression of the conduction of the neuromuscular reaction through the calcium channel. So calcium gluconate 6 hourly helps to reverse the neuroparalysis in addition to the ventilation.
Thank you, sir. Thank you so much for those word of wisdom. Can I request Dr. Sampada madam to add her expert opinion?
Thank you, ma'am. After, I think, saying anything after Dr. Bavaskar sir would not be a correct suggestion. But the only thing is, like what sir used to say, what I've heard him say in the 2005 conference is that you don't need monitoring equipment. You just need your eyes, you need your ears, you need your hand, and you need a stethoscope. And I think that says so much. Having a child who comes to you with a little bit of drowsiness, with a little bit of ptosis, not wasting time, intubating him on time, and giving proper respiratory support, I think it would be the key to saving at least 30 to 35% of deaths due to snake bites. So I think sir's paper also mentions that from 40%, the deaths came down to 3 to 5%, just by giving adequate ventilation. So along with neostigmine, atropine, I think the key would be to identify that this particular baby is going into respiratory failure is one, by ptosis, two is by the induced sleep, and third thing is that as compared to adults, if you look at the body surface area of a child, it's much low. So the envenomation dose, which would be not toxic for an adult, would be extremely toxic, especially a baby who is malnourished, especially in the rural setting, sleeping in the house with a great envenomation. I think that would be the key, where the site is and how is the nourishment and nutritional status and the age of the baby. So I think just adding to that what sir has said. Thank you.
What we say in the crate bite, licks
Thank
the
you
skin
so
and
much.
bites the respiration. Okay. Okay.
Thanks a lot.
Yes.
Ma'am, after having wonderful presentation and pictorial presentation by Aditi, let us move to the second speaker. I invite Dr. Shreyas Surpure. Sir is from Kushiji Hospital, consultant at Ahmednagar. He won the best
Dr. Shreyash, you can start.
Okay, ma'am.
Yes, you are this slide.
Okay. Good evening, everyone. Today's topic for our presentation is vasculotoxic snake bite. I'll start with my presentation with one case scenario. Slides are not moving.
Try double click. Yes.
Yes, ma'am. So a 10-year-old boy, he presented with, he was returning from the school, and there with his friends at around 5 p.m. in the evening, suddenly he had a bite on the left leg while walking in the field. His friends informed people nearby and brought him to the nearby hospital. On arrival to the hospital at 6 p.m., there was a swelling of the entire left leg with ecchymotic patches and mucosal bleed in the mouth. So now let's discuss how will we proceed further in this case. Just a general information about the most common death about the snake bites. Most common death in India are mostly due to the 4 common species of snake: cobra, crate, Russell viper, and saw-scaled viper. Today's my topic being related to vasculotoxic snake bite. In brief, I'll discuss about the mechanism of how the Viperidae causes a vascular toxicity. First, it releases the procoagulant enzymes, which activate the different steps of clotting cascade and inhibit in formation of fibrin, resulting in DIC or consumption coagulopathy. Also, hemorrhages in the snake, in this Viperidae snake venom, damages the endothelial lining of blood vessels, resulting in local and systemic swelling. Hyaluronidase helps in spread of venom through connective tissue. Clinical presentation, as we all know, there may be some local effects as well as some non-specific, but specific to vascular toxic snake bite are local bleeding, bruising, tender lymphadenopathy, coagulopathy, bleeding from the bite site, and renal toxicity. Now, proceeding towards the management of pediatric vascular toxic snake bite, we'll start with the first aid treatment. As Aditya said, we have to do the right thing, and we don't have to whiz, that is washing the wound, incision, suction, and electrical shock. Pressure immobilization method has been advocated as reliable method. Second thing, immediate clinical and ICU management. First, it would be strict bed rest to avoid even minor trauma. We have to secure airway, breathing, and circulation. We have to assess the level of consciousness, and we have to give CPR if needed. Also, the site of bite and time of bite is important, and snake identification has to be done. Proceeding towards the laboratory evidence of envenomation. First, as we all know, 20 minutes whole blood clotting test, in which we take few ml of fresh blood in a test tube. We keep it undisturbed for 20 minutes. And if the blood is still liquid at 20 minutes, then the patient is known to have hypofibrinogenemia, a result of venom-induced consumption coagulopathy. Other thing that we can monitor is, we can check is platelet count, which is decreased in viper snake bite. WBC count, which neutrophilic leukocytosis in systemic envenoming. Blood film, we may see the features of hemolysis, fragmented RBCs may be present. Also check for plasma and serum. If pink or brown, it may suggest gross hemoglobinuria or myoglobinemia. Aminotransferase and creatinine kinase may be elevated if local damage or generalized muscle damage. Urea creatinine, these are usually high in case of renal failure. Most important, PT-INR, if INR are more than 1.5, it is suggestive of coagulopathy. Also, urine examination can be done to screen for hematuria, hemoglobinuria, and myoglobinuria. Dipstick test is positive in all three of it. Centrifuged urine sample, if it is showing a pink color, it indicates hemoglobinuria, whereas clear supernatant indicates myoglobinuria. A few slides about the anti-snake venom. It is a immunoglobulin purified from serum or plasma of horse or sheep that has been immunized with venom of more than one snake species. It's polyvalent, neutralize the venoms of, it is a polyvalent, polyvalent which neutralizes the venoms of several snake species. Indications being systemic manifestations of envenoming, severe local or regional effects of envenoming, and edema of skin lesions extending more than 2 joints. Contraindications are not as such. How to administer? It is a reconstituted, freeze-dried or liquid antivenom, which is diluted in approximately 5 to 10 ml of isotonic fluid per kg body weight. Dose, it is same as in adult, 10 vials stat as infusion over 1 hour. If no improvement, then second dose can be given. The dose is same because the dose does not depend on the weight of a kid, but it depends on the dose the venom has been injected into the kid. Hence, it is not related to the related to the weight of a kid. Close monitoring is required, and adrenaline should be kept always ready before administering ASV. Local administration at the bite site is not recommended. Now, when to repeat a ASV dose? Just this topic related to vascular toxic. The guidelines are after 6 hours, if whole blood clotting time, if it is abnormal, a further dose of 5 to 10 vials should be administered over 1 hour. This 6-hourly pattern is repeated until a coagulation is restored, and maximum 30 vials can be given. If no improvement, we can consider giving fresh frozen plasma. Some indications of ASV in special situation. Newborn and small infants, the dose is same, but the total volume is restricted to 5 ml per kg and given more slowly to prevent fluid overload. Anti-snake venom dosage in victims requiring life-saving surgery. Here, the initial dose is not 10 vials, it's 25 vials. And the third is victims who arrive late. If coagulopathy is present, we can administer ASV. Now, few adverse effects of ASD. They are categorized into 3 types. Early anaphylactic, as we all know, the signs of anaphylaxis like urticaria, irritability, hypotension, angioedema, shock. In these things, we have to stop ASV immediately, administer adrenaline intramuscularly, and repeat every 5 to 10 minutes if symptoms persist. Also, if there is a subsidence of these symptoms, we can restart ASV slowly after clinical stabilization. And in case of shock, we have to give normal saline bolus and adrenaline infusion can be given. There can be pyrogenic reactions, which is usually the pyrogenic features in the ASV. usually happens after 1 to 2 hours after ASV. It doesn't need much of it. It just needs paracetamol and other cooling procedures. Late reactions that can be seen are developed after 1 to 12 days post ASV, which may be like fever, vomiting, urticaria, arthralgia, etc., which needs treatment by prednisolone for 5 to 7 days or oral chlorpheniramine. Sorry, prednisolone with or without chlorpheniramine. Now, other thing that that can be done in vascular toxic snakebite is we have to do volume replacement. We have to closely monitor for urine output and maintain urine output of almost more than 1 ml per kg per hour. If patient has an intravascular volume depletion, fluid challenge bolus can be given. Observe the patient closely while this is being done. The fluid challenge must be stopped immediately if there is a features of pulmonary edema. Other important feature in vascular toxic snakebite is coagulopathy. This may be associated with low platelet count, which is suggestive of DIC or consumption coagulopathy. Fibrinogen level and FDB can be done to confirm this diagnosis. In case of coagulopathy, FFP fresh frozen plasma can be given 10 to 15 ml per kg within 30 to 60 minutes, over 30 to 60 minutes within 4 hours of ASV administration. Now, what is our aim in this? Our aim is to return to coagulation function, which is as defined as INR of less than 2 at 6 hours after ASV administration. Bleeding, which may lead to anemia. So we have to target our PCV because mostly if, in case of vascular toxic snakebite, we may see there is a bleeding in such cases. So try to maintain a PSV of more than 30. If less than 30, then blood transfusion may be needed. Also, avoid intramuscular injections in such cases. Heparin and antifibrinolytic agents and corticosteroids are to be avoided in vascular toxic snakebite. In case of shock or myocardial damage, correct hypovolemia, and if hepatomegaly or RALS develop, initiate inotropic support because this may suggest signs of congestive cardiac failure. So we may start with dopamine, dobutamine, and if does not respond to fluid resuscitation, we may start with inotropic support. In sepsis, noradrenaline is inotropic agent of choice in septic shock. Sometimes these patients may complicate into acute kidney injury. So sometimes we may need to do dialysis in such patients. Indications being blood urea of more than 130 or creatinine of more than 4. Sorry. Fluid overload leading to pulmonary edema, hyperkalemia, or unresponsive to conservative management and uremic complications. So what would be our take-home messages? Our take-home messages would be identify the early signs of envenomation, manage with ABC approach, start ASV as early as possible, prepare for anaphylactic reaction, and prevent or treat coagulopathy and multi-organ failure if present. Also, create public awareness since most of the snake bites are due to non-venomous snake bites, so which may need no treatment as such, but just close monitoring. So we have to create public awareness about the same. These are my references. Thank you.
Yes. Thank you, Dr. Shreyas, for that wonderful presentation. Thank you so much.
Yeah.
You had a wonderful slides also. Very good.
Thank you, ma'am.
Can I request Dr. Sampada ma'am to add her expert comments?
Thank you, Dr. Shreyas, for such a lovely presentation. To start off with, as far as the Viper family is concerned, I think the most important risk factor is the bleeding and the angiopathy, which goes on simultaneously. And I think the first indicator of bleeding that happens is the gum bleeding that you really have to look for. So any child who comes with history of Viper bite, I think gum bleeding is something which needs to be monitored. When you're securing an IV line, when you draw samples for lab collection, when you keep the samples, your eyes should be looking at the samples as well as the IV lines. If you have an IV line which is bleeding profusely and a sample which has not been coagulated for the next 20 minutes or so, be assured that this has to be hemorrhagic disorder which is going to set in subsequently, and send your PT-INR and APTT samples right away. Like Dr. Shreyas has said, that why that 4 to 6 hours gap is that because the ASV can revert these things. So I think the moral of the story is that don't wait for n number of lab investigations. When you have somebody who's got a bite which is very, very necrotic, has a lot of edema oozing, a lot of lymphatic involvement, and a super onset lymphatic obstruction and swelling ensuing with a blood not clotting, start ASV as quickly as possible so that within the next 3 to 6 hours, the parameters start coming back to normal. And of course, To save the limb, I think the fresh frozen plasma is the key. So none of the drugs are going to help, but fresh frozen plasma. There is a saw scale viper, which we have seen that causes a little bit of neuroparalysis also. So sometimes that picture can be a little more confusing when both the things do come in. But at the end of the day, you're going to maintain the circulation, you're maintaining the airways and the breathing, and you're going to look at the parameters. One thing is that in neuroparalytic, you were really not worried about the kidneys, the muscle injury, the damage. Here, the kidneys shut down really fast, A, because of bleeding, and B, because of the lysis, intravascular lysis. So once you have a red urine, once you have myoglobinuria, it is our duty to actually monitor the kidney, the urine output, and urea creatinine. So that, I think, is a take home. So hit fast, because Viper really hits us fast.
Thank you, ma'am. Thank you for
Thank
that
you, ma'am.
expert and guiding us. Thank you so much. Dr. Bavaskar, sir.
The
Please
most important thing is don't wait for 20-minute coagulation test. No sooner white soccer if there is edema, its corresponding patient has been envenomed. Next is regional lymphadenopathy. That is very important thing. And very important in Russell Viper bite, the bite soccer, continuous bleeding start from the Fags mark because of local DIC. That is the most diagnostic. And as earlier, you can give prophylactic adrenaline, start ESC. That is very important. If everybody afraid of anaphylaxis, and most important is renal tenderness, which is very commonly seen in the pediatric even, because of this, and renal failure can be prevented by early administration of antivenom. That is 10 to 20. We administer generally 20 vials, which prevent the renal failure, though it is not mentioned in any protocol. But our experience says more antivenom is at the earlier stage, renal failure less likely to occur. And that is very important. And lymphadenopathy, looking at the lymphadenopathy, and the 20-minute whole blood clotting test should be done in new dry glass test tube, not in the plastic tube. Please remember, in the plastic tube, it interferes with the Hagman factor and blood remains incoagulable. It's a false message will be given to the Russell Viper bite victims. So that is very important message which I want to give.
Thank you so much for that, sir. Practical tips and clinical clues to the management. Thank you so much, sir. Thank you, Shreyas. Now let us shift to the third speaker from Marathwada zone. Am I
Just
audible?
1 minute.
Yeah.
Just 1 minute, ma'am.
Who is that?
Prabha Kare.
Prabha,
Ah,
ma'am.
yes, ma'am. Yes, Prabha, ma'am.
Sir,
Yeah.
sir, just I want to ask Bavaskar sir about the doses of ASV basically. He just said just now he said that 20 vials he is giving, and then another dose may be required for the ASV. So in neuro and as well as the vasculotoxic snake bite, what could be the dose, sir?
Oh.
Both showing differently, but we also giving 20 vials, and then required in Viper we add more, and for the neurotoxic we don't add anything like that.
In the neurotoxicity, if you give under 10 vials, if there is no improvement in half and 1 hour, you can repeat
Yes.
our 10 vials, no further no requirement.
Yeah.
Russell Viper, you have to monitor giving
Yes.
ASV upon 20-minute coagulation test, which should not
Yes.
be done 6 hours before after giving the last dose of ASV.
That's good. Yes, sir. Thank you so much. Yes, we are following
Okay.
that.
Thank you. Thank you, sir. Thank you, Prabha, ma'am. Let us switch over to the third speaker from Marathwada zone, Dr. Prasad Dham. Dr. Prasad is practicing at Sadhak Childcare Hospital, Dharashiv. I invite Dr. Prasad to present his presentation on protocol management of scorpion sting. Over to
Am
you.
I audible?
Yes, sir. Yes, sir. You are. You're audible.
I welcome respected Dr.
Sir, make it
Raj-
full screen. Please make it full screen, sir.
Ma'am, 2 minutes.
Amal, sir,
Yes,
please.
sir. Yes.
Welcome the senior pediatrician, respected Dr. Rajendra Kulkarni sir, who is today's MMC observer. Sir, kindly unmute and say a few words. Kindly guide us.
Hello.
Yes, sir. You are audible, sir.
Yes, welcome, sir. Welcome, sir.
Welcome. Thank you. I am very happy to be MMC observer for this MAHA-IP's academic program. It's very important. I congratulate the team of MAHA-IP for organizing such wonderful, practically oriented and important topics for discussions. And one more thing which I would like to appreciate about this team is they are mining the talent of Maharashtra. And that is very much nice that all the promising opportunity of our state are getting tapped and are getting known to the MAHAIP members. I appreciate that, and I congratulate all the faculties. And icing on the cake for today's topic is the guest of honor. Who else can be the best expert for this toxic CMA, I will say, but none other than Himmatrao Bavaskar, sir. So that's a wonderful session. Kudos to you, sir. My bow, and please go ahead. Thank you. Thank you very much. Congratulations again, and wish you all the best.
Yes, thank you, Dr. Rajendra Kulkarni, sir, being our MMC observer, and thank you for inspiring us all the time. Thank you, sir. Over to you, Dr. Prasad. Please start your presentation. Dr. Prasad Dharm.
Hello, friends, and the respected MAHAIP dignitaries. The topic to me is scorpion bite management protocol. So we will start with one imaginary case just so as to see the various components of this scorpion bite management. There is a 3-year-old male child brought by parents in the morning with the complaints of excessive cry, altered sensorium, sweating, and excessive drooling of the saliva. So there are 4 questions, and we will see one by one, and we will move forward. What is the probable diagnosis? What are the pointers to the diagnosis? And what are the parameters to monitor the baby? And what is the management in the emergency room? So first question is, what is the probable diagnosis? So whenever we see a young infant or young child brought with excessive cry, definitely the first thing we should look, that is any history of any bite is there. And the scorpion bite is one emergency that we will not see any bite mark, only we will see the baby who is excessively crying. So it is a true medical emergency, and we have to observe the child so as to get a diagnosis. So baby with a sudden onset of excessive cry, we should always suspect a scorpion bite, especially in the rural setting. So there are 2 main species, the red scorpion, that is the most poisonous, and black scorpion, which usually with prominent local symptoms with less systemic symptoms. So we will spare 2 minutes just before the management so as to look the clinical features. So scorpion venom is in the real sense is a real cocktail, because it is a mixture of so many toxins, neurotoxin, nephrotoxin, cardiotoxins, and all these are the toxins, and this venom is rapidly acting. So we have to move fast. We have to reach the diagnosis as earliest as possible, and so that the 70% of the maximum concentration of the toxin is reached in just 15 minutes, maximum concentration in around 1 to 1.5 hours, and it is very rapidly acting venom, and we have less time in our hand to treat the child. And as the child is having the more bodies, less weight and more body surface area, usually the scorpion bites in a small child is usually fatal. So prominent clinical features is a severe excruciating pain at the site of the bite, and this is the symptom that is usually comes first and goes last. So tap sign we can try this, because there is a hyperesthesia. The tap around the bite induces the severe pain and the withdrawal symptoms, also paresthesia and the tingling numbness. But the real thing, which as a clinician we must just carefully examine the baby so as to look for the cholinergic storm symptoms, which comes early and goes early, such as vomiting, ropey salivation, priapism, excessive sweating, skin diarrhea, bradycardia, and hypotension. So actually the first 4 symptoms, usually they warn that the forthcoming sympathetic storm which is going to harm the baby. So sympathetic storm usually comes 4 to 6 hours, tachycardia, hypertension, tachypnea, convulsion, tremors. Also, there are certain specific symptoms such as pulmonary edema in the respiratory. So we should carefully look for the sputum, tachypnea, grunting, and also we should use the stethoscope so as to auscultate the fine crepitations. Neurologically, it is sometimes we see the ophthalmoplegia, ptosis, and stroke-like episodes. Typically, that is one of the differential, though there is usually we get a organophosphatate poisoning, we can get a similar symptoms that a cholinergic storm, but the smell is usually very obvious. So that is one of the differential said in the textbook. Cardiovascular, we get direct myocarditis, toxin-induced, and autonomic storm. So then we move forward to the management. The local pain control just as to give to the relief to the baby. Ice packing, xylocaine without adrenaline infiltration, NSAID paracetamol to control the pain, and oral diazepam in small dose to sedate the baby so as to relieve the anxiety. But the cornerstone of the management of the scorpion bite is a prazosin. It is a magic drug, and in the real sense, it has revolutionized the management of the scorpion bite because it has brought down the case fatality rate from 30% to 2 to 3% with just 1 or 2 doses. So in the real sense, it is a true cellular pharmacological and antidote, and also it is a cardioprotective. It suppresses the sympathetic flow, and it all the actions of the scorpion venom, they are mediated by the alpha and the beta toxin. It counteracts the both. So the route is the oral route. Dose is a 30 microgram per kg per dose. Drug comes in 1, 2, or 5 milligram dose, and sustained release tablets are usually not used here. It is usually we should carefully look for the signs of the cholinergic storm, and we should not give the prazosin just only for the local pain. So give only if some features of the storms are present, and usually the 30 microgram per kg per dose, first dose when we give, then we have to monitor for the blood pressure, pulse rate, and the respiration of the baby, and we should wait for at least 2 to 3 hours. If there are no if there is no signs of any response, we can repeat the prazosin, and we can usually the 4 to 5 doses are required, not more than that. And one thing is that do not lift the baby after the prazosin first dose for at least 2 to 3 hours so as to avoid the first dose hypotension. So cornerstone is a prazosin. Then comes the scorpion antivenom. It is usually not available. Where I practice in Dharashiv, we have actually not given scorpion antivenom at all. Whatever the patients I have seen in last 12 years, not too many, but actually the prazosin was more than enough. But if we combine the prazosin with scorpion antivenom, then it hastens the recovery, and it is usually one bite of the scorpion gives 1.5 milligram of the venom, while the 1 ml of the scorpion antivenom neutralizes the 1.2 to 1.5 mg of the venom. And the dose is 30 ml diluted in the 100 ml of the NS, infused over 30 minutes while monitoring the allergic reactions. There are also other management issues such as fluid and rehydration due to the salivation and sweating. It is the rehydration is, as far as we should try give orally, and if there is persistent vomiting, then we can try IV resuscitation. Also, pulmonary edema we should continuously monitor because it's like a pheochromocytoma symptomatology, such as we should continuously monitor the blood pressure, look for priapism, salivation, hypertension, pulse, tachypnea, and tachycardia. So inotropic support for the pulmonary edema with dobutamine and sodium IV sodium nitroprusside. So these are some of the slides I have made so as to simplify the scorpion bite. Thank you for giving me chance.
Okay, great. Thanks, Dr. Prasad, for excellent presentation. We could learn a lot from your slides. Thank you so much. Over to you, Dr. Sampada, ma'am, to add your take-home messages.
Thank you, Prasad sir. I think it was a very crisp presentation. I think in the scorpion bite, to start with, the most important factors that we have to consider, it's much more easy in male children because we have a monitoring thing for priapism. I think it's an excellent monitoring tool. So clinically, if you look, the three things that are very, very important as far as scorpion bites are concerned is one is priapism, that for monitoring and to look for further doses of prazosin. Second thing is hypertension. That is one thing which really denotes whether you need to give further doses or no. Ensuing hypertension again would warrant another dose of prazosin. And the third thing is a pulmonary edema which is coming, which often is the killer. So I think identifying, putting your stethoscope in the basis and looking for signs of pulmonary edema, even if you don't have glorious monitoring equipment, just a stethoscope and monitoring blood pressure should be the key of saving these children. And prazosin, as we all know, has an excellent response. It gives a very good response. So I think without making you all wait in between sir's views and the topic, may I request Himmatrao Bhaviskar sir to kindly enlighten all of us.
Please, sir, we are very much eager to hear you, sir. Please.
Now, the problem is that now when the child is crying and extreme becoming a cold, child pain will stop. So local pain, when there is minimum local pain, vomiting, sweating, and cold extremity in priapism is a diagnostic such child is going to develop pulmonary edema, tachycardia, or cardiogenic manifestation. The prazosin is pathological and physiological antidote. It is not a simple prazosin because it reduces the preload and afterload, just like sodium nitroprusside. That's why it is called oral sonide. Next important thing, what happened autonomic storm? Glucose is raised, hyperglycemia. From the liver, potassium is liberated, hyperkalemia, and insulin is suppressed because of alpha receptor stimulation. Prazosin is phosphodiesterase inhibitor. It increases cyclic GMP. It stimulates insulin secretion. By stimulating insulin secretion, it take out the glucose, circulating hyperglucose in the cell along with the potassium. So it's always, that's why I say in hypotension, prazosin is not contraindicated, provided there is vasoconstriction or cold extremities. Cold extremities, not the BP, but the cold extremities are the indication of prazosin. Next important thing is, of course, patient should be well hydrated. Most importantly, don't take prazosin so lightly. Prazosin should be administered by the doctor or nurse itself. Don't hand over to the mother. Mother may forgive. And next important thing, after giving a prazosin, doctor should monitor whether the prazosin has absorbed or not, or starting action. Reduce the BP, opening of the cold extremities, patient complains severe local pain, patient become comfortable, go to sleep, tachycardia reduce, recurrent crisps are reduced. That is very important. Now, scorpion antivenom is easily available from Apki. Prazosin take more than 24 hours to 72 hours for recovery. Out of which 5 to 6% patient may develop children, particularly tachycardia, which will require dobutamine and subsequent management. But if you give antivenom with the prazosin, my trial is published in RCT in the British Medical Journal, that prazosin plus ESV is given some recovery is within 8 hours. Patient goes home within 8 hours. So, and antivenom is since available. So, if you want to reduce the doctor labor or doctor anxiety, you must give antivenom in a patient with a vomiting, sweating, salivation, along with the prazosin. Very important thing, which I recently published in the Lancet, that is 2000, Lancet 200, very prestigious issue of the Lancet, when 200 is completed by the Lancet now. In that, I have seen a child of 3-month-old baby had a scorpion sting, and she was really irritable, crying, vomiting, sweating, difficult to put her eyes to. That time no pediatrician was available, so we were in the panic whether she will take. Mother has tried to tear the paste in the honey and milk, but could not swallow the tablets. So and that was no alternative, no injectable prazosin available. Ultimately, mother is the highest pediatrician. Mother is a professor of pediatrician. So we given the tablet to mother and said, if this tablet go to the stomach of a child, then child will survive. She prepare a paste, apply to the nipple, and force the child to suck, and the child survived. That is published in the Lancet. And the Lancet has given me the question that was query that how the child can child have a test, child would have refused. Then the Indian pediatric has mentioned child developed taste sensation after the 4 months, and he was tried of 3 months. So this is a very, very important thing. So prazosin should not be taken so lightly. The most important thing is hydration, and never become panic at all. Pulmonary edema, you can treat with a non-invasive ventilator. Never intubate the child, because non-invasive ventilator is indication for the chronic, this acute LV dysfunction, which patient will improve. And if availability of prazosin, and yes, no victim will develop pulmonary edema, recovery is 100%. Appearance of severe local pain, which was absent initially, is sign of recovery, is a sign of vasodilatation. Thank you. Thank you, ma'am.
For today. Thank you so
Yes,
much, sir.
next.
Thanks, Swapna ma'am. Thank you. Let's move to the next speaker. Dr. Swapnil Talwekar from Wardha IIP. Dr. Swapnil is consultant at Vinayak and Child Care Hospital, Wardha. Dr. Swapnil is requested to talk on bite management.
Yes, Dr. Swapnil, you can start.
Yeah, yes, I'm audible. Namaskar, Mahayapi. Good evening. Sashtang Dandavat, Padma Shri Himmatrao Bavaskar sir, dignitaries joined here. So get into the business. I bring regards from Siddhivinayak Mother and Child Care Hospital. My topic is lizards, spiders, and insect bite management. Slide is not moving, I guess.
Double click.
Yes.
Double click.
So yes, done. So starting with the
Yes,
lizard
go
bite first, the venom is conducted via the capillary action, which is more of like vasoactive kinase, and the toxin is no neurotoxin, and that any enzyme that significantly affects the coagulation. By epidemiology wise, young children are more at risk, but also young adults, adolescent one are more at risk as they do not comprehend the risk of the venom and the bite. Prognosis is excellent. Death not recorded till death, but the potent in infant and toddler with the prolonged bite could result in a death. Clinical presentation history is very obvious. Of bite is usually clear. Severity of envenomation is depends on the length of the time lizard remain attached to the victim. So that is most important in history taking. Differential diagnoses are like snake bite, especially when history is not clear. Lab studies, CBC, WBC, and all this depends on the sign symptoms. Diaphoresis, serum electrolytes can be offered. Pre-hospital care before reaching the hospital is all supportive. Specific treatment medication in hospital, no specific agent used to treat lizard envenomation, entirely a symptomatic treatment. Broad spectrum antibiotics to provide gram-negative organism coverage. Corticosteroid has no role in envenomation management. Local anesthetic like diglocaine, epinephrine should be avoided along with that. Antihistamine like diphenylhydramine is the drug of choice. Cimetidine can be tried. Analgesic like fentanyl is the drug of choice. Next topic is the spider bite management. Pathophysiology is alpha letotoxin, which causes the all predominantly neurological and autonomic symptoms. Again, prognosis is good. Max recovery is fully. Clinical presentation, initially pain may be unnoticed or travel. Infant may present with unexplained crying. That's what we seen with other stings also. Physical examination like abnormal vital signs, hypertension, tachycardia, tachypnea, and occasionally hypothermia. Diaphoresis, severe muscle cramping, abdominal rigidity, neurological effects, including mild weakness, fasciculation, ptosis has been described in the envenomation. Complications like respiratory difficulties, hypertensive emergencies, rhabdomyolysis, compartment syndrome, that can be there. Lab studies is morely focused on to exclude the alternate differential diagnosis. CBC, cardiac marker, neuroimaging, CT abdomen, and ECG. Pre-hospital care and emergency department care is more of like supportive care only. Envenomation severity has been graded in 3 grades: grade 1, grade 2, grade 3, mild, moderate, severe. I haven't mentioned the details, but I must like to mention here, like in mild cases, there are the stable vital signs along with the local pruritus or local redness. In grade 2, we have some muscle cramping, some vasculotoxin, some muscle crampings, and some symptoms along with normal vital signs. And in grade 3, that is severe, we have all kind of symptoms along with the abnormal vital signs. Medication and treatment managed with opioid analgesics, sedative, hypnotics, and hypertensive. Antivenom may be indicated in severe cases. Calcium gluconate is no longer recommended. Analgesic is morphine sulfate is a drug of choice as reliable. Benzodiazepine, lorazepam, diazepam can be tried. Midazolam, yes, intranasal is an option for pediatric patients now. As we all know, nasal spray are available. In toxin, immunization, TT should be administered. Booster in previously immunized individual, yes, it is recommended. How to prevent now? Like brush, do not crush. That is the statement. Brush, do not crush if spider is seen on the body or clothing. If we try to crush, it can have more venom to the victims. Long-term monitoring for the patient. Instruct patient to return if any of the following signs symptoms occur, like hematuria, rash, joint pain, swollen lymph nodes, difficulty in breathing, and signs of infection. So third topic of mine is insect bite management. Moving to it quickly. The term bug bite is commonly used to denote both bites and stings inflicted by the members of the phylum Arthropoda. Out of these, 4 are clinically significant classes, and we are going to discuss only Insecta, the 4th one. And the Insecta one has a Hymenoptera, includes the bees, wasps, hornet, fire ants, mosquito, redbugs, fleas, lice, bits, many. So let's discuss one by one. So Hymenoptera, the classical extent of the reaction after the bite has been divided into 3 groups. Mild local, large local reaction, and the systemic reaction. The mild local has a redness, itching, pain, swelling. Large local will be increase in size, swelling more than 10 centimeters, and 5 to 10 days to get resolved. In systemic reaction, mild to life-threatening conditions like cutaneous response such as urticaria and angioedema, bronchospasm, large airway obstructions including tongue or throat swelling, and laryngeal edema, hypotension, and shock. These are the that include in systemic reactions. Now, how to treat? Simple thing, like remove the stringents right away, wash the sting site with soap and water, ice or cold sponging, mild relief, apply ice for 20 minutes once every hour needed. Antihistaminics such as diphenhydramine, hydroxyline, non-sedative loratadine, ranitidine, cetirizine for itching and swelling. Plain paracetamol or ibuprofen for pain relief as needed. Hydrocortisone cream on sting can help relieve redness, itching, and swelling. Most insects require no additional medical care. For the treatment of LLR, limb elevation if the sting is on the extremities, oral prednisolone can be tried. Exclude secondary bacterial infection while treating. Next is fire ants. The venom of fire ants is composed of alkaloids causing intense and burning like pain. 2 central hemorrhagic puncti from bite surrounded by the ring of erythematous papule caused by the sting is distinctive characteristic of fire ants. This papules develops into vesicle and then sterile pruritic pustule over 6 to 48 hours. Most reactions are the localized dermatological findings. Treatment is similar to that of Hymenoptera stings. Second one is the flea bite. Bites typically present as a erythematous papule, often with a hemorrhagic appearing center. Severe pruritus can be there. Topical calamine lotion, corticosteroid, and systemic antihistaminics are the treatment of choice. Next, moving to the tick bite, feed by cutting hole in epidermis and injecting. Bites are usually painless. Wide variety of rashes and other dermatological findings can be there. May present as a pruritic urticarial lesion. Uncomplicated ticks, nothing to care. Routine wound care. Removal of the ticks are more important. Fine tip tweezer grasping the tips as close to the skin can be possible, pulling upward with steady and gentle pressure. Next one is mosquito bite. Bite produce minimal trauma, as we know. often not felt by the host. Most common are the pruritus and cutaneous fandling. Symptomatic and ice application, topical corticosteroids and systemic antihistaminics are what we needed. Next one is the bedbug. Usually the bites are linear or in a zigzag fashion, small papular punctum without surrounding reaction. Treatment is symptomatic, topical glucocorticoids and systemic antihistaminic to control the pruritus. Secondary infections, appropriate antibiotics in case of secondary infections. Fly bite is while obtaining blood usually quite painful with significant cutaneous inflammation. Urticarial wheals and the papules will be there. Treatment, symptomatic, ice application, pain control with acetaminophen, NSAIDs through washing of the wound and systemic antihistaminics for the itching. Next one is lice. Head lice and pubic lice are the things. Younger children in daycare or elementary school has a more head lice present on the head, eyebrow and eyelashes. Symptom, sensation of something moving in hair, itching or other visualization of the nits or lice. In pubic lice, pubic hairs occasionally can be found on eyelashes and eyebrow also. Similar symptoms are similar to that of head lice. Treatment, pediculicides, many of which are available without prescription also. Common over-the-counter treatment include pyrestrins and permethrin 1% lotion, oral ivermectin 200 microgram per kg repeated after 10 days later. That is not FDA approved for this purpose. Nits removal should be with fine comb, eyelashes application of ophthalmic grade petroleum ointment on the eyelid margin for 10 days. Next one is body lice, similar with the head lice, and like direct contact can also occur through the clothing, bed lines and towels. Symptoms are the similar pruritic secondary to allergic response, areas of pyoderma. Treatment like washing all the clothes, bed linens and towel with hot water for itching, systemic antihistaminics and antibiotics for secondary infection. And the last one is sugar bite. Bites are usually not felt initially, but the allergic reaction develops as an extremely pruritic red papules. Treatments of trigger bites are, if the trigger present on the skin, can be removed with scrubbing the skin with soap and water. Intense itching, in case of intense itching, topical calamine lotion, corticosteroids and systemic antihistaminics. This is all from my side. My topic was of multiple insect bites and lizards and spider. So I had to rush quickly to respect the time frame of the program. I thank you, MahaIP and organizing team. Over to organizers. Thank you.
Yes, congratulations and thank you, Dr. Swapnil, for making it crisp and wonderful. Thank you so much. You have cut off your slide almost to the 50%. We are so grateful to you. Thank you so much.
Yes.
Can I request Dr. Prabha Khaire ma'am
to
add her expert opinion?
Just two, three things. Just so congratulations, Swapnil. You made it possible because this is a very long topic. But we don't worry about the lizard and spiders because we are in a Indian continent, so we are not having that lizard and spiders. But in jungle, yes, definitely we come across for the spiders. Insects, yes, definitely we are seeing routinely many of us pediatricians are come across for the crying baby, the crying child suddenly is playing out and crying. They come with the crying, and there could be a bites, different types of bites. The only thing I will take the message from Bavaskar sir, that prevention is the mother of cure. That what prevention you will do is the prevention that fully covering the baby, children's or babies when they are going out and at the home as to prevent these insects bites especially. And the another thing is in your first aid box, just keep a hydrocortisone, because hydrocortisone cream or the Betnovate cream you can keep when there is a rash, when there is a irritation and all that. That can be your first aid in your emergency box also, or in your first aid box. That almost every bite means all the bites, they can be preventable and they can be treatable. No casualty can happen. But yes, definitely we should care about the anaphylaxis. Basically, bees and wasps that may cause sometimes. So we should be careful for that. Okay, thank you so much.
Ma'am, for your expert guidance. Thank you so much. Can I request Bavaskar sir also to add his expert tips and take-home messages?
Commonest death we found, that is because of the honeybee stings. That is very important. And many stings suddenly pass to the victims, and many histamines are liberated, and patient usually die of shock. Here, the drug of choice first is adrenaline, and remove the stinger by any means. By maximum, you remove maximum stinger, the victim will recover. So we have seen cases die of honeybee sting. That's a very important to remove the stinger, to give adrenaline.
Yes. Thank you, sir. Thank you so much.
Okay, thank you. Let us
Thank you,
continue.
sir.
Sir, how the stinger can be removed? With a forceps?
Yes,
With the
forceps. You can,
forceps.
yes,
With the force.
by the nail, your nail, long nail, you can remove the stingers.
Okay, sir.
That stinger removing is very important. Whole body.
Today's last speaker. IIP, and Dr. Kshitij is currently assistant professor at GMC Miraj. Dr. Kshitij has given a topic to talk on marine environmentation management. Over to you, Dr. Kshitij Gunde.
Thank you, ma'am. So my topic is marine environmentations and its management. When this topic was given to me, I thought, is it that common that we should discuss this topic? But when I went into the incidence and epidemiology, there is actually though there is no global accurate data available for incidence of marine envenomations, there are very few reports available, one of which stated that only in Florida and Eastern Australia, approximately 1 lakh of such cases happen per year. And India has a coastal line of around 7,516 kilometers, and Maharashtra having around 720 kilometers of coastline. So I think this explains why this topic is important. And another thing is, most of the hazardous marine animals are found along the Indian coastline. So while most marine envenomations are mild, systemic, and life-threatening reactions as well as delayed presentations can occur, the pediatric population is at higher risk for serious reactions due to less body surface area and less body mass. The venom load can be higher comparatively. But the important thing is, rapid and effective and simple treatment measures can improve the immediate outcomes, like decreasing pain, stabilization of symptoms, treating anaphylaxis, and they can also minimize the secondary complications. So after seeing that, I came to a conclusion that it may be unfamiliar, but it is not uncommon. So we divide the marine animals into invertebrates and vertebrates. So these are the common poisonous marine animals. Invertebrates are box jellyfish, Portuguese man of war, Irkundi jellyfish, molluscas like cone snails and octopus, and sponges and urchins. And vertebrates are stingrays, lionfish, stonefish, and sea snakes. So starting with box jellyfish. As you can see, the box can measure up around 20 centimeters in length, and tentacles can be 3 meters long, and it is transparent blue in color. So to identification of the marine animal is very important in the treatment. So we should know how common marine animals look. So this is the poisoning mechanism. The box jellyfish has nematocysts stored in the thread and barb, and the nematocysts have the poison, and they have a mechanism to deliver this whenever the sting occurs. Box jellyfish sting should be treated as medical emergency, and it is classically identified by a rash called a ladder rung pattern of rash, which is seen in the pictures. Clinical features: maculopapular erythematous rash, classical ladder rung pattern, burning pain, and edema. And why is it a medical emergency? Because of its systemic cardiotoxicity. Mortality rate can be up to 25% if not well managed. So management involves application of vinegar for 30 seconds, which wipes out the nematocysts, removal of the tentacles by just applying a shaving cream and scratching by card,
We can pour hot water around 45 degrees hot for 20 to 30 minutes. Hemodynamic management and antivenom, though it is not available in India. The next is Irukandji jellyfish. It is a very tiny jellyfish. You can see a 2 rupees coin is $2 coin is besides it. It is that tiny. So classical feature is Irukandji syndrome, which is a sympathomimetic toxidrome. Classically, patient presents with an impending doom, anxiety, fear, diaphoresis, abdominal pain, tachycardia, hypertension. It can lead to toxic cardiomyopathy and cardiogenic shock, but most cases recover in 24 hours. Treatment again is hot water shower, vinegar irrigation, analgesic including morphine, fentanyl, and controlling the sympathomimetic toxidrome. We are worried about hypertension and cardiac failure, so we can use glycerin trinitrate and phentolamine, and magnesium sulfate is also used in these cases. Third is Portuguese man of war. This looks like this. Clinical features, envenomations are less severe, local pain, rash, skin necrosis. Less common is hypotension and cardiotoxicity. Rarely death occurs. But the important thing is we should avoid using vinegar in this sting, because vinegar can lead to rupture of pneumatocysts and increase in the toxicity. So treatment is supportive hot water irrigation, removal of tentacles, and analgesia. Next is cone snail. Cone snail is like, as we can see, it has a small proboscis and a shell. So the thing to remember is the clinical features can start from sharp pricking sensation to unbearable pain. It contains a conotoxin, which is a causes neuromuscular blockade. Initial symptoms include muscle weakness, ptosis, difficulty swallowing, to respiratory arrest. So it can present as descending paralysis. This lasts typically for 12 to 36 hours. Management is removing of the spines, which may require X-ray or sonography. Hot water immersion for about 90 minutes because it is a heat level toxin, and brief intubation may be required. Intubation is required only for some 24 to 36 hours because the signs and symptoms usually last for 36 hours. One interesting thing is, because of the property of conotoxin to block the neuromuscular site, several conotoxins have shown promise in preclinical models for treatment of pain, convulsions, stroke, neuromuscular block, and cardioprotection. Next is blue-ringed octopus. It contains a tetrodotoxin which inhibits voltage-gated sodium channels. So it can also cause flaccid paralysis, hypotension, less commonly respiratory failure, and death. Treatment is also supportive. Manage the airway breathing circulation, manage brief mechanical ventilation is necessary, and pressure bandage. Next is sea urchins. So mechanism of injuries is painful puncture wounds with severe muscle aching lasting for about 24 hours. As we could see, frequently spine beaks, there are sharp spines which could beak off in the wound, leading to granuloma or synovitis. Nausea, vomiting, paresthesias, weakness, abdominal pain, syncope, and hypotension can occur. There are high chances of secondary infections. So mainstay is hot water irrigation, antibiotics which should cover Staph, Strepto, and Vibrio. The routine antibiotics which used are Septran, fluoroquinolones, doxycycline, ceftazidime, and meropenem, and may require surgical irrigation and surgical removal of spines. This is stingray. This is a famous person on National Geographic Channel, Steve Irwin, who died due to stingrays. Injury pattern has two phases. Mechanical is due to barbed sting. As we can say, the tail has a sting which can harm at the end of whip-like tail, and venomous due to a gland at the tail base is injected into the victim. Symptoms include pain, laceration at the puncture site, nausea, vomiting, muscle cramps, barb lodged in the skin, pain, and swelling. Local hemorrhages, hypotension, dysrhythmia. As I said, most famous death of Steve Irwin was killed by penetrating injury by that barb directly into the chest and heart. Management, hot water immersion, systemic analgesia, and local analgesia. Plain films to evaluate for foreign body. If lodged in the chest, should be treated like stab wound and removed in operating room, and tetanus and prophylaxis for antibiotics. Next is stonefish. Now, it is the most venomous of the spine fish. Venom is compatible to potency of cobra venom. Symptoms include severe pain, edema at the site of the sting, headache, severely painful cyanotic puncture, wound, necrosis, and ulceration. Complications include include seizure, paralysis, heart block, heart failure, pulmonary edema, and death can occur within 6 hours. Treatment begins with stonefish antivenom, but it is not available in India. All spines should be removed, hot water immersion, treat pain, debridement, and consider antibiotics and tetanus prophylaxis. Next is lionfish. It's the third most toxic spine fish. It causes pain, erythema, vesicles, and necrosis. Treatment same for as stonefish, except for antivenom is not available. And last is sea snakes. Their venom is a neurotoxin acting at the acetylcholine receptor and hemolytic and myotoxic compound that causes muscle necrosis, hemolysis, and renal tubular damage. Approximately 80% of bites do not result in envenomation due to small and easily dislodgeable fangs. Initial symptoms, if envenomation occurs, include painless pinhead-side fang marks, and roughly 36 minutes later, 30 to 60 minutes later, muscle pain and stiffness, nausea, vomiting. It can cause paralysis, respiratory failure, muscle necrosis, and renal failure. Treatment, there is antivenom which reduces mortality rates up to 3%. And without it, the mortality rate can be around 25 to 30%. Apply pressure immobilization dressing, maintain airway and breathing, and admit to hospital. These patients require close monitoring of electrolytes, urine output, as they may develop rhabdomyolysis, renal failure, and hyperkalemia. Patients may require hemodialysis. So take-home message is marine envenomations are an important encounters considering the geographical scenario of India. Most of the envenomations remain unreported. Though most of the envenomations are mild, fatalities can occur. Quick 5 steps for management are hot water irrigation, remove the tentacles or debris, provide analgesia, prescribe antibiotics, and watch for systemic symptoms for at least 6 hours. Rapid and effective treatment improves the immediate outcomes. These are my references. Thank you.
Oh, thank you, Dr. Kshitij, for taking us to the underwater travel. Long time. I lost watching beautiful animals. Thank you so much. Thanks for diving deep into the topic and presenting a very uncommon topic beautifully before us. We could see lovely marine animals too. Can I request Dr. Prabha ma'am to add her expertise?
He just took us too deep in the diving, and his presentation is really wonderful. He just said me and he corrected it very well and presented it very well. So there are 5 toxic animals, we can say, marine lives under water, and we have to take care. We should see them when we are having the coastal area, Arabian and the Bengal seashore. So pediatricians should be vigilant for treating those, identifying those
Kshitij, you can stop sharing.
Poison should identify that poison marine envenomum because of the marine lives. And in first aid, you can say, he elaborated very well about the first what to do. But yes, definitely I'll put few points that when in a coastal area pediatrician, or maybe we can, when we go to enjoy the coastal area, at that point we should have some first aids in our box, that is gloves, then if possible little bit vinegar, and the hydrocortisone ointment, and that antibiotics. Basically all those things. After all this management, we should not forget about the giving tetanus also. And then just I would again suggest one diverse alert network, that DAN, which is having that first aid about the hazardous animals or hazardous marine life. That is another good book, handbook, which we can use, or pediatrician who are there at the coastal areas, that can be used. That is my again message to all.
Okay, thank you, ma'am. Thank you so much. Thank you. We are eager to listen to Bavaskar sir also regarding this topic.
I got a poor experience regarding this marine, but I have seen a case of the long time shown to me of the sea snake bite. Now sea snake bite mortality is very high because of rhabdomyolysis and hyperkalemia, heart failure, cardiac arrest. That is the commonest cause. So we should first important. Now antivenom of sea snake is not available. Still we can use as a paraspecies routinely available polyvalent paraspecies toxin. A most important treatment hyperkalemia must be known. One first drug of choice is calcium gluconate. Then we can get a diuretics, then dialysis. Then we can give salbutamol, if available. And most important, we have seen in this bites is the resistant hyperkalemia. Many times may not respond to dialysis. In such cases, Lancet has already mentioned, we can give glibenclamide. That is open the sodium potassium channel and enter the potassium in the cell. So glibenclamide, which is the most well known and published in the Lancet, that glibenclamide is a drug of choice resistant hyperkalemia, which is commonly seen in sea snakes. Okay.
Okay. Thank you so much.
Would like to ask to Dr. Bhaviskar, sir. Sir, can you guide us about snake bites in newborns? Means up to what dose we can give, and dose is same, but how to give, because volume.
Volume, you say you can dilute in 100 cc. There is no problem at all, and you can give 100 and remove
10 vials in 100 cc.
Yes. It's no need to
Sir,
give.
have you any experience? Can you tell your experience about this newborns,
No,
especially
we
for
don't.
snake bites?
Newborn we rarely treat because newborn we send to the pediatrician.
Protected, no, they are protected.
No, we have.
No, madam. We are coming in our
Acha,
center. We are coming with this, that newborn having dog bite, then rat bite, and all this. So I had asked sir especially this question.
No, newborn we don't have, but 1 year, 6 months that we have with that experience and with the same doses like neurotoxin.
Thank you, sir. Thank you, Prabha ma'am. We are very grateful to have Dr. Nitin Shah, your gracious present. Thank you, sir, for being with us. Thank you so much. For further proceedings, here we end the session.
Any comments, sir? Nitin Shah, sir, any comments? Any questions? Bhaviskar sir is there.
I purposefully joined today because these bites we don't see sitting in high-rise buildings in a city like Mumbai. I mean, I don't remember when I saw the last snake bite. Maybe when I was resident. That's why. And these are so much of Indian context with Dr. Bhavaskar's input in the several media. And I think very rightly he was then honored by the government of India. But I think those are path-breaking researches which have really helped the world how to treat, especially on the scorpion bite and the other bites. So I really wanted to learn. Should I get one such case? Maybe I'll be a little more wiser than all of you.
Thank you.
I was like
Thank
a student
you,
today, to tell you very frankly.
Yeah.
You should not
Thank
get
you
such
so
cases.
much, and hearty congratulations all the speakers for your wonderful presentation, and thank you experts, and thank you Bhaviskar sir. For further proceedings, I hand over mic to Dr. Neha for the vote of thanks. Over to Dr. Neha. Dr. Neha.
Thank you, Manjusha ma'am.
Before that, any comments from Bhaviskar sir or Sampada ma'am or Khaire ma'am?
No, this is very good lesson to everybody, because this is a rare thing now. This is going now. This is the rare bite thing coming to the urban people, but occasionally it can happen. So that is very important to know. So many times they even in the Kerala they keep prazosin in their purse. So important. So that is important. We should know about this at all. Sting and bite should be known because it's a acute, life-threatening, time-limiting emergency. We should not lose our children, please.
Yes.
Yes,
Yes, just one comment is that we often talk about ASV or we're talking about anti-snake, but the availability of ASV in the private setup becomes a big challenge sometimes. And here I think getting and procuring it on time would be something that really, because in the medical college also for us in a private medical college, we struggle to get ASV. And we have a corporation college next to us, so that makes our life easy. But I do understand it's not readily available for everyone. But the thing is, at least don't sit on the patient. If it's not available with you, it's not going to be made available with you. Please refer the patient on time, because time is the limiting factor over there.
ASV is available at PSC. because patient reach earlier to the PSC.
Yes.
Patient reach to tertiary care when is ventilator required, not the ASC. So
Nitin sir.
PSP is very important, where government is supplying to the primary health center. In a PSP is available to a
Yes,
primary
all
health
over.
center.
So Amol,
Yes.
I have two
Yes, it is
comments.
available all over Maharashtra in PSCs and
It
all.
is true,
Yeah.
ma'am. The only problem is in the city, it is becoming little difficult because then they get it only at government clinics, or they will get it at Sassoon Chandra Hospital as far as Pune is concerned. So that is the only problem.
So I have two
Nitin
comments
sir.
about that. It's almost mandatory for every hospital to store anti-snake venom.
Yes,
In
yes.
fact, we had a very false alarm of a child playing in a garden where there was a classical two-fang mark seen, and whether we didn't know, we didn't wait, and the hospital actually had stored ASV. So I think every hospital has to store ASV. And number two, I would request Amol and maybe the Maharashtra IP that based on this symposium and other experts putting in their views, you can make a very short, very practical protocol how to treat these 4 or 5 common poisoning. Put it on the IP Maharashtra website, because it will be very useful for people who are not used to treating them but cannot refer them. Like suppose there's a snake bite in Bombay, I can't refer them to Dr. Bavaskar. So I have to treat. So how do we treat is everything important. These protocols will be very, very useful for people.
Yes, sir. Yes, sir. Yes, we'll do.
That is great. That is great thing that we can do, sir. It is
Yes,
possible
so
that we
nice.
can do that. That
So
that
nice.
is very good. And this is really a wonderful session which is conducted by the MAHA-IP and WC wing, and we are really privileged to be a part of this program. The topics which is selected now, that those are very those are practically important to the all corners of the Maharashtra and almost the India also. So that that is the best part of this webinar or session. And so I'm really happy to be a part of this session. Thank you so much for giving me the opportunity.
Thank you, ma'am. Thank you.
Go to Neha. Gangolia sir, any comments?
Dr. Gangulia, sir, you want to say something?
No, it was really excellent, and many things I got to learn and know the things, though we are practicing at rural. But what Dr. Nitin sir said, yes, we should come out, because from this only we can pick up good these algorithms, or say the how to go about protocols to manage the thing which can be put on the MAHA-IP website. 100% that we should do. Thank you, everyone.
Okay, good night, everyone. Bye-bye.
Namaskar, Nitin sir.
Thank you.
Neha, for vote of thanks. Over to you, Neha.
Yes, ma'am. Yeah. Today, the topic chosen was very interesting and thoughtful. And after a wonderful session on various topics of envenomation, everyone is waiting for my vote of thanks. So, friends, for a very long time, man struggled to encounter their venom. The battle is only half won. Speed and high level of intensive care are a must. A fight with the venom, unfortunately, begins when the victim reaches us. Public education is crucial. The traditional wisdom is often out of place. We need more Dr. Bavaskars with tireless efforts to overcome this malady. I would like to specially thank respected Dr. Himantrao Bavaskar sir, who agreed to grace our webinar as guest of honor. He has enlightened us with his presence and expertise comment. He is a true role model for any young physician. Also, very thankful to Dr. Sampada Tampolkar ma'am and Dr. Prabha Khere ma'am for graciously accepting our invitation for being the expert for today's Tuesday Take program. Their superb guidance and useful comments were really very helpful. I also thank our MAHA-IP President, Dr. Ramakant Patil sir, and Secretary General, Dr. Amol Pawar sir, for giving us full support and the MAHA-IP platform. I would thank Maharashtra Medical Council and our MMC observer today, Dr. Rajendra Vasantrao Kulkarni sir, for joining and giving us one MMC point. I also thank Dr. Hemant Gangulia sir and Dr. Nitin Shah sir for joining us today and giving their views. I would thank all the 5 speakers.
Dr. Neha, before you end, just one question. I don't know who spoke about lizard, but we come across in the villages when lizard falls in the milk, and they are not sure of what to be done. It's a very common thing, and we are surrounded by lizards at rural place.
Sir, I want
That's
to
not bite. That's not bite,
I want
sir.
to answer that. Don't worry when lizard falls in the milk, because lizard poison is not a poison. It is not a poisonous thing. But yes, definitely social stigma, social awareness, and people may get panic about it, because last week Chhatrapati Sambhajinagar had faced the problem of food poisoning because of lizard, but it is not because of the lizard. It is because of the lizard. It carries the salmonella. It carries the salmonella, and because of that, there might be the poisoning. So you can discard that.
Sorry, Neha, to interrupt you. Please continue.
No,
Yes,
sir.
sir.
That's
I forgot that actually.
That's why the topic was added. Lizard was added because there
Proper
is
question
lot of
asked.
And so
curiosity.
another thing is home lizard, that is Jacko. Those are not
Yes.
poisonous at all. Just when they are touched with your body, you just wash your body or a part, and that is the only thing.
Yes.
Because that carries the salmonella on their body. That's why that may be the poisonous thing there. It is not a poisonous, but organisms which is taking us to that panic. Yes, thank you.
Thank you, madam.
Thank you, ma'am,
Yes,
for
Dr.
enlightening us with that point. I would thank all the 5 speakers of today, Dr. Aditi, Dr. Shreyas, Dr. Prasad, Dr. Swapnil, and Dr. Kshitiz, for preparing and delivering their topics fantastically. Would like to thank our Women's Committee Chairperson, Sonali Shrivate ma'am, who has always been an elder sister to me. I also thank Dr. Manjusha Sherkar ma'am and all the zonal coordinators of Women Committee for all the support and help in organizing today's program as well as the year round. Thankful to Pallavi ma'am for being always there and solving all sorts of technical issues. Last but not the least, I thank all the attendees on Zoom as well as YouTube Live for joining us. Good night, everyone.
And last, thanks to Dr. Neha.
Thanks to Dr. Neha. Yes, backbone.
Most welcome, sir.
भावस्कर सर, तुम्ही तुमचे मोलाचे 2 तास महाराष्ट्र IIP साठी दिले, महाराष्ट्राच्या बालतज्ञांसाठी दिले, त्याबद्दल तुमचे विशेष आभार.
Thank you. No problem. It's my
Good night,
pleasure.
sir. Good night all.